Our next speaker in this session is Dr. Thomas Zachary Paull. Dr. Paull is a orthopedist. He is a fellow with Dr. Peter Cole in St. Paul, Minnesota. And Zach, are you on the line?
Yep, I'm here.
Hello, good morning.
Good morning.
Thanks for putting on a tie.
Yeah, absolutely. Glad to be here. This is my first CWAS meeting, so thank you guys for having me. I'm gonna share my slides here.
We see it correctly.
We see it correctly.
All right, perfect. Well, thank you very much for having me today. Like you said, I'm coming from St. Paul. I do want to say that I am in between residency and med school, so I'm a research fellow that works for Dr. Cole and just graduated from North Dakota this last spring. So the goal of the talk today is to introduce our lateral implosion injury and our CHUSHA classification. So hopefully I say CHUSHA enough in this talk that you guys start using it too, but you're the first ones to hear it. So pretty exciting stuff. So we'll talk about what forequarter lateral implosion was defined as, what the actual classification system entails. We'll look at a couple of cases, and then we'll look at a review of 133 patients that we did at our trauma center. So for this purpose, forequarter lateral implosion injury involved more than 2 ribs fractured and a shoulder injury. So the shoulder injury would be a scapula fracture, clavicle, proximal humerus fracture, or a dislocation of the AC or SC joint. So for CHA, our number 1 would be 2 to 4 ipsilateral fractured ribs, so ipsilateral to the injured shoulder. So CHA 1, 2 to 4 ribs. CHA 2, 5 plus ipsilateral fractured ribs, and then CHA 3 would be 2 plus ipsilateral fractured ribs, and then having contralateral rib fractures or a sternal fracture. So our SHA becomes SHA 1, clavicle, AC, and or SC joint injury. SHA 2 would be a scapula and or proximal humerus fracture. And then SHA 3 would be a combination of 1 and 2. And so going through this, we have 3 categories for each of the 2 sections. I think if my math's right, that gives us 9 total categories to go through. So in summary, you could have any combination of a SHA and a CHA to give you our designations for this classification. So this is an example of a case. He got into a fight with a bull. Unfortunately, he lost, but you can see the extreme medialization of his shoulder, and then the awful chest injury that he has there. So this would be a CHA 3 and a SHA 3 because he broke both of his clavicle, his scapula, and then all of his ribs on the left side, and he's got contralateral rib fractures as well. So this is just our 3D reconstruction. These are kind of fun to make, but you can just see the gross deformity that he had and the horrible injury. So don't fight bulls. So we looked at 2 years worth of data at our trauma center, and we came up with 133 patients that met our inclusion criteria, which were ICD-9 codes for any of those injuries and having a combination shoulder and chest injury. So the mean age of our patients is 58. Most of them were male. I guess they're out there doing stupid stuff. Their mean ISS was 22, an ICU admission rate of 37%, and a 30-day mortality of 10%, which we thought was pretty significant. So associated injuries, a lot of them with head injuries, spinal fractures, other ortho injuries, and a fifth of them underwent rib fixation, a third went shoulder girdle surgery, and then 13% had fixation of both the ribs and their shoulder. So for mechanism of injury, the majority of them were falls. Otherwise, we have our motorcycle accidents, motor vehicle accidents, ATV accidents, pretty common stuff. So to characterize the chest wall injuries that these patients had, on average, they had 6 ribs fractured, not rib fractures, 6 ribs fractured. and over a quarter of them had a flail chest injury. So when we look at where these ribs were fractured, 80% of the patients had ribs 1 through 3 broken, 90% had ribs 4 through 6, and then as you go on, 67, 7 through 9, and 26 for 10 through 12. So that makes sense when we're looking at people that were hit directly in the shoulder and had that lateral implosion effect happen. So to be included with their shoulder injury, the majority of them were clavicle fractures, followed closely by scapula, very few acromion, AC, SE joint injuries, and proximal hinge fractures as well. So this is kind of some of the data that we pulled out of these patients. We did a review, we went through everything. I'll zoom in on this later, but this just kind of highlights how we have 9 groups. And so in our columns here, we have CHA 1, 2, and 3 for our chest injuries, followed by SHA 1, 2, and 3. So even though we had 133 patients, you can see that our patient numbers get kind of small as we divide into 9 groups. So here's our number of patients for each group. Interestingly, very few people break their scapula and have less than 5 rib fractures. As you can see that the CHA 1, CHA 2 classification is only 3 patients, whereas you get up to 28 when you go to CHA 2. So they're breaking more ribs when they have a scapular fracture. Otherwise, it's kind of standard across the board for the CHA 1s, and then very few people that had the CHA 3s. So our ICU admission rate, well, we were just kind of looking at, these are all just descriptive statistics. We weren't able to be powered for having proof of difference between these groups, but we were just kind of looking at trends to characterize these injuries. And obviously more research needs to be done if we're going to start using this classification. But as we increase in our CHA classification, more ribs fractured, these people are injured more. So higher ICU admission rates. And that's a trend that continues for all these stats that I'm going to show you. So then we want to compare how they do as we go from SHA 1 to SHA 3. And interestingly, SHA 3 actually has lower ICU admission rates. And we'll look at some other stats here. So 30-day mortality increasing, mortality potentially as more ribs are fractured, but no mortality with the SHA 3 classification. Head injuries, again, increasing percentage of head injuries as we go from SHA 1 to SHA 3, but we decrease here in SHA 3 compared to our SHA 1. And so our thought for why this happens, this is just more trends with spinal fractures, is that when someone breaks both their scapula and their clavicle, it kind of has an accordion effect or a shock absorption effect, sort of like how your car hood would crumple if you get into an accident, preventing injury to, or preventing more serious injury, I should say. So here's solid organ injury, again, increasing as the number of rib fractures go up, but then with our combined SHA 3, we have a lower percentage. So this is our 63-year-old in the bullfight. He actually had his ribs fixed originally by a cardiothoracic surgeon at the time of injury and presented to the senior author 4 months after with multiple rib non-unions, a scapula non-union, and a clavicle non-union. So he was reconstructed, and this is what he looked like after. I think he underwent 3 reconstructions for his ribs as well. This is another example of a 74-year-old male that was in a bicycle crash. He was admitted directly after this incident, and he actually underwent fixation of 2 ribs, his clavicle, and his scapula at the same time. And so we submitted this to AAOS, but you guys are the first ones to hear it. It's the first time that it's presented, and we hope that you start using the CHA classification system. I believe that Dr. Paull is here as well. He's the lead author, and he'll be available to help me answer questions if I get into hot water. So thank you very much for having me. I really appreciate it.
Dr. Paull, thank you very much. What a fascinating bit of research, and I'm really liking the cha-cha thing. I think it'll catch on. Dr. Van Wyck has a question. Suzanne?
Yeah, thank you so much. It's such an interesting classification. I was wondering for the CHA2, so is it 5 fractures or is it 5 ribs fractured?
They're all 5 ribs fractured. And so we know that a rib can be fractured multiple times. So for the purpose of this classification, it's number of ribs fractured.
Okay, clear. Thank you.
We have Dr. Edwards on the line from the UK. John, we've made you a panelist. You want to, it looks like you had a comment or two to make about this classification system. Are you there, John? John, can you unmute?
Sorry, we're back to the regular screen. Good morning, everybody. Good afternoon to those in the East. It's really a question and perhaps a comment more than a question in terms of how you think this is actually going to be useful in terms of a clinical classification. You know, how is recognition of the injury pattern going to change things? You know, is it going to result in a special management protocol that you otherwise wouldn't do, or is this just an esoteric way of saying actually if you fracture your clavicle, you know, the anterior and the posterior struts, then you don't need to worry too much about the chest. So it sounds very interesting. I'm just interested to see how this is going to pan out from a clinical perspective.
I think Dr. Paull had a comment. He just stepped into the room here. What did you say?
It's giving us prognostic information. Certainly because it correlates with ISS, mortality, spine fractures, and injury.
Yeah, so if you guys could hear that, he just mentioned the prognostic value that we have for these numbers and the increase in severity of their head injuries, spine injuries, ISS scores, ICU admission rates. And I think we do need more numbers and try to prove some statistical significance between the classification, but we're looking at only 2 years worth of data. I feel that we got a pretty good start on really defining how these patients are going to do after their injury. And then I think another thing that you can look at is the more severe their shoulder injury, getting ortho on board right away. And if they're stable enough, potentially undergoing fixation of that whole shoulder to help alleviate and to help with their recovery too.
Well, Dr. Paull, I erroneously inflated your level of training. I apologize for that, but please accept our congratulations. I think everyone is very impressed with how your command of this topic and your poise and maturity belie your youth. So thank you very much.
Yeah, no problem.
Dr. Cole, I've made you a panelist. Do you want to say hi to the group and make a comment or two?
Yeah. Sure. Thank you. I'll just say that this is certainly a pilot study. It's an evolution. I think Dr. Edwards' question certainly indicates that we need to also correlate functional outcomes on the different classes in order to be able to correlate which injuries will benefit the most from greater stabilization. I think many of us, including patients that you and I have shared, Tom, believe that immediate stabilization of displaced lateral forequarter injuries is important to help promote the rehabilitation of patients. Just like chests feel better when you fix the ribs, so do scapulas and clavicles. And so I think it is important to address all the displaced and unstable injuries in these combined injuries. But I would assume that we will, learn and discover more as we expand the cohort and build significance statistically amongst the different groups.
Gentlemen, thank you very much. Peter, it's nice to see you.